who is Kunjal Patel, from the United States, from the FACS group, who's going to be presenting on weight changes after initiation of an Integrase Strand transfer inhibitor among adolescents and young adults with perinatal HIV in the United States, the Descriptive Cohort study.
Thanks, Fatima. And thank you to the organizers for the opportunity to present some of our ongoing work looking at weight changes. I'm going to repeat this title again, Fatima. Weight changes after initiation of an Integrase Strand transfer inhibitor, or INSTI, among adolescents and young adults with perinatal HIV in the United States. So this is our first look at this study question within the Pediatric HIV/AIDS Cohort study, or FACS. And so as such, our analysis was designed to be primarily descriptive in nature. So INSTI-based regimens are now preferred for people living with HIV. However, data among adults raised concern about increased weight gain after initiation of INSTI-based regimens compared to regimens of other drug classes, as can be seen in the graphs below. This observation led to further questions. Is this a potential effect of INSTIs as a class of drugs, or is this an effect of individual INSTIs? Is this actually an effect of the NRTI backbone used with the INSTIs, or is the potential effect of INSTIs on weight gain modified by NRTI backbone? Are there other modifiers of this association, such as sex or racism, age, treatment experience, or health at the time of INSTI initiation, or maybe even genomics? Or is this potentially an effect of the prior regimen or comparator regimen? What could be the potential mechanisms of this effect if, in fact, it is true? Could INSTIs affect appetite, or is this really a return to health phenomenon? Lots of open questions, all within the concurrent context of the obesity epidemic, particularly among adolescents and young adults in the United States, where the rates of obesity range from 22 to 40%. So we are not going to try to answer all of these questions within our current study. Rather, we chose to focus on looking at individual INSTI-based regimens among treatment-experienced adolescents and young adults with perinatal HIV in the United States, with the specific objectives of describing characteristics at the time of switch to an INSTI-based regimen, and describing and comparing weight and BMI trajectories in the year before and after switch to one of these INSTI regimens. Our overall study population included treatment-experienced adolescents and young adults with perinatal HIV in the United States-based FACS AMP and AMP-UP protocols, who initiated bictegravir, dolutegravir, alvategravir, or raltegravir. Our exposure of interest was a participant's first documented switch to any of these INSTIs, which meant that a participant may contribute data to more than one INSTI if, for example, they had initiated a raltegravir-based regimen and then later initiated a dolutegravir-based regimen. Participants were followed after switch until INSTI discontinuation or the last study visit before January 1st, 2022. For the analysis of weight and BMI trajectories, our study population was further restricted to those who initiated their INSTI between 15 to 29 years of age and had at least 2 outcome measures, with at least 1 measured after the switch to the INSTI. Those who became pregnant during the year prior to switch or during follow-up were excluded. We utilized piecewise linear mixed effects regression models, adjusting for age and CD4 count at INSTI initiation and stratified by sex, to estimate and compare trajectories in the year after versus year prior to INSTI initiation. We observed 137 switches to bictegravir, 261 switches to dolutegravir, 179 switches to alvategravir, and 147 switches to raltegravir. Overall, 63% of our study population was female, 68% self-reported as Black, and 29% self-reported as Hispanic, with some variability across INSTIs. The biggest difference across INSTIs was age at INSTI initiation, with most switches to raltegravir occurring at younger ages compared to the other INSTIs. This, of course, is just due to how INSTIs were rolled out into clinical practice. Consistent with age, the majority of switches to raltegravir occurred in pediatric care, while 45% of switches to bictegravir occurred in adult care. Overall, 29% of our study population had experienced a CDC Class C event in their lifetime. Switches to raltegravir occurred at higher viral loads than switches to bictegravir. Generally, CD4 counts were similar across the INSTIs. The variable I really want to highlight is prior ARV regimen type. Again, consistent with how these INSTIs were rolled out in calendar time, we see that most switches to raltegravir occurred from a PI-based regimen, while most switches to bictegravir occurred after a prior INSTI-based regimen. We had wanted to look at weight changes stratified by prior ARV regimen type, but as you can see on the last row, we are missing a lot of data on this variable. So this figure shows the duration that we had on the INSTI-specific regimens. You can see that for most of the INSTIs, we had a median duration of follow-up of over 2 years. However, for bictegravir, as the new INSTI on the block, we only had a median duration of follow-up of 1.5 years. So this figure shows the predicted means of weight by INSTI and sex. In the purple or blue, we have the males, and in the green, we have females. The vertical line is time of switch to INSTI, or time 0. On the left of the line, you have years prior to switch to the INSTI, and on the right of the line, you have follow-up after switch to the INSTI. So let's go through each of these boxes individually. So for bictegravir, we see that prior to switch to bictegravir, slopes were increasing on average, and then after switch to bictegravir among males, the increase in weight gain actually slowed down for males, and for females, the rate of weight change was negative on average, indicating some weight loss. I do want to point out the 95% confidence intervals around our slopes, just to show you that we had a lot of variability in our data set, again, due to the sample sizes once you stratify by sex. Looking at dolutegravir, again, please notice that in the years prior to switch to dolutegravir, weight was increasing, and after switch to dolutegravir, on average, the slopes increased. You can see that in the slopes. The slopes increased for both males and females. Again, note the variability in our 95% confidence intervals. Given this level of variability, we can't really say that the increase in slopes after switch to dolutegravir were any different from the slopes prior to switch to dolutegravir. The results for alvategravir were similar in that slopes increased in the year after switch to alvategravir for both males and females. And for valtegravir, the results were similar to bictegravir in that for males, the rate of weight gain decreased after switch to raltegravir, and for females, the rate of weight change was negative, indicating some weight loss on average. Again, wide confidence intervals. This figure shows the predicted means of BMI by INSTI and sex. I added in the dotted line at a BMI of 25, showing the typical cutoff for overweight. Looking at bictegravir, we see that BMI was increasing prior to switch to bictegravir, and after switch for males, you see that the rate of weight change was actually negative, increasing perhaps some average weight loss, and for females, the rate of BMI gain actually decreased after switch to bictegravir. For dolutegravir, we again see that BMI was somewhat increasing over time prior to switch, and after switch to dolutegravir for both males and females, the rate of BMI gain did increase in the year after switch to dolutegravir, again, though some large variability in our sample. The results for alvategravir were again similar to dolutegravir, suggesting some increased in the rate of BMI gain after switch to alvategravir for both males and females. And the results for raltegravir were different for males and females, in that for males, after switch to raltegravir, the rate of BMI gain increased, while for females, after switch to raltegravir, the rate of BMI gain actually decreased. So I feel silly to say this, given the large variability we had in our sample sizes, But given what's been published before, we are a large descriptive study to understand INSTI use and weight gain among treatment-experienced adolescents and young adults with perinatal HIV in the United States. We were unable to stratify analysis by prior regimen, as I highlighted previously, due to missing data issues. And we were also unable to stratify by weight and BMI at INSTI initiation to look at the return to health phenomenon, again, due to missing data issues. We did not collect specific reasons for ARB regimen switches or discontinuations in FACS, and there was also some heterogeneity in NRTI backbones. So in summary, we observed that rates of weight gain in the first year after initiation of INSTI-based regimens among treatment-experienced adolescents and young adults with perinatal HIV were not substantially different from observed weight gain in the year prior to initiation. While we compared post-switch to pre-switch, our results are consistent with the Spanish cohort study of younger adolescents and young adults with HIV that were presented at CROI, showing no significant variation in weight over time, comparing dolutegravir to non-dolutegravir-based regimens. We do want to point out that across all the INSTIs, we did observe increases in BMI over time, particularly among young women, which suggests the need for interventions beyond treatment decisions about specific ART. In future work, we do want to stratify by TAF versus no TAF, and we hope that our study motivates a future hypothesis-driven comparative safety study of INSTIs with longer follow-up. I finally want to acknowledge our funders and thank our study participants and their families, our clinical sites, our community advisory boards, our data management center and coordinating center. This is a list of our past and current FACS sites and the geographic distribution of our current clinical sites. I'm happy to take questions and even some suggestions about future work in this area. Thank you.